This is Jerry Hesch from the Hesch Institute in Aurora, Colorado. And my client is a physical therapist. And she had an injury to her ankle, but she has no idea what happened. Can you tell us about it?
Yeah, it was after my second child. I just noticed a little bone loose in there, and it was an avulsion fracture of the fibula,
Uh-huh.
and a tear of the ATFL, but for no...
Yeah, the anterior talofibular ligament tore.
Yeah.
Okay. And so you had a surgical repair. I see a scar down here, and I see a little scar there,
Yeah.
and out here. So tell us about the repair. They repaired the ligament.
They repaired the ligament, and then they there was a full thickness cartilage defect of the talus, and so they did some stem cell from my hip and filled it in.
Uh-huh.
And it was non-weight bearing for 6 weeks after that.
Okay. And how long ago was this?
That was 3 years ago.
Okay. And you notice the ankle is still a little bit loose?
It just still hurts.
It still hurts?
Yeah, in the joint. So
okay.
I never noticed the ankles being loose per se, because I was a big runner, but so it doesn't feel different to me than it used to.
What does that mean?
Meaning, like, I didn't know it was loose.
Oh, okay. You still, yeah.
I still don't know it's
Alrighty.
loose.
Okay. Okay. And the drawer test is negative. Even if I invert you, it's still negative. But what is positive is you have excessive inversion if you compare sides.
Okay.
And when I do the inversion test on the left side, it's, looks to me like 25 degrees, maybe 30. Okay. This one is looking like 45. And then if I overpressure it, I even get more.
Okay.
Okay. If I take if I take the right one into inversion to end range, and then I try and get a little spring mobility or test the end feel, it's really strong. Okay. Not this one.
Okay.
Okay. Now your everters now called fibularis muscles, the ones on the outside of the lower leg that basically evert the foot, are inhibited.
Okay. I
want you to show me how strong you are, and I want you to evert this foot. Okay, and don't let me break it. 1, 2, 3, go. And I'm able to break it. Let's do it on the right side. 1, 2, 3, go. And I can't break it. You're very strong.
Okay.
Okay. So what I do is I look for and you do have a background of hypermobility syndrome. You have lots of knee extension. Your heels are 6 inches off the table.
Right.
All right. So I'm just looking at appearance of the talus. It's only accessible for a small portion right there. I'm looking at dorsiflexion, and I'm testing end feel. And with hypermobile folks, you have to take up the slack slowly, just to make sure, because there's going to be a little bit of creep because they have a lot more elastin than, say, I do.
Yeah.
So we just hold it there for a while. And I'm looking at position of fibula, and do you know that this fibula appears to be inferior?
Does it really?
By appearance.
Okay.
Okay. But function is more important than how it looks, right? So what I'm going to do is I'm going to load and spring the fibula on the right. Do you feel that little bit of spring? Okay, and it bounces right back, so it's got good integrity. And on this one, I'm not able to take up the slack. I can't get it to telescope up. Whereas most people, there's that little tiny bit of micro motion. You don't have it, so I'm not able to spring it. Okay? Now, of course, when the fibula is pulled downward, the lateral malleolus shifts forward. So looking downward, yes, it looks like this is forward.
Yeah.
And if I spring, I do an anterior to posterior spring on the right malleolus, there's a little bit of play there, but it feels strong. On this one, I don't get any play.
Okay.
So it's basically stuck there.
Okay.
Now, I'm going to test forward spring. That is also absent. Okay, sometimes you can do it, but everybody's a little different. And then I'm testing fibular head. I'm not getting any spring at the fibular head going anteriorly. On your right side, you feel that little bit of play?
Yeah.
Little bit of give. Okay? So I'm going to ignore that. I'm just going to continue filming. And I'm going to go ahead and treat the fibula. So I'm going to glide it superiorly. I place the foot into a little bit of eversion. And I'm actually going to push through the calcaneus. I'm going to evert the calcaneus.
Okay.
And then I'm going to glide it upward and take up all the slack.
Okay.
I like to do this over the course of 2 minutes. But I'm going to be just slightly more aggressive than usual. And I'm going to go ahead and do 30 oscillations. Alright, so we oscillated that 30 times. And I'm going to now test it to see if I can glide it superiorly. And I can now take up the slack in it.
Okay.
And I can spring it, and it does spring upward. Okay? I'm going to take the malleolus and push into the table, taking up the slack. The calcaneus stabilizes, and now I can spring that. Okay? So I'm going to look at inversion now, and you know, you have at least 30 degrees, but you don't have the 45 you had before. Overpressuring it doesn't make it go very much more. So it feels more stable, so that could be what we call a positional instability. I'm sorry, positional hypermobility. The other thing is that there's also reflex phenomenon going on with the type 3 receptors and ligament capsule and the Golgi tendon organ inhibiting muscle function. So sometimes you create a little positioning, which is micro movement. You can't validate that with a CAT scan, MRI, or X-ray. You cannot. Let's have you evert the foot. Okay, show me how strong you are. 1, 2, 3, go. And now you're very strong. Okay, so I think you had a loss of micromotion in that ankle complex. Mm-hmm. And I don't think that's a true laxity. It might be a little more joint play than the other side than the right, but over time that might strengthen, and as you use it, it's going to get stronger because it's no longer inhibited.
Okay.
So a week from now, you're going to be a lot stronger if you do nothing at all.
Okay.
But you're a PT, you know how to work on the ankle, and we now have spring mobility there. So just out of curiosity, could you walk down the hall and back and come tell me how you feel?
Oh, yeah. I just feel a little bit of maybe pinching in the front.
Pinching? How interesting.
Yeah.
Interesting. Well, let's keep looking at it. Come lay on your back.
All right.
So I'm pleased with the micro movement of the fibula, and we had already checked the talus, and the distal tibia has good spring mobility. I'm going to check fifth ray, and that glides forward, and I'm going to check the cuboid. And cuboid has good freedom up and down.
Okay.
I'm going to test the midfoot. And this is where we have a limitation.
Okay.
I'm not able to pronate that midfoot. Okay? That's surprising. I didn't expect that. This one goes beautifully to an end range of pronation, and then I can overpressure it. Okay? So the way I like to treat, see that only, the forefoot and midfoot only everts about 10 degrees. This one goes easily 25. Okay? So I think the naviculus is driving the bus. And the naviculus is made for rotation and a little bit of up and down glide.
Okay.
And rotation. So what I like to do is capture it with 2 hands and just traction it forward to gap the joint.
Okay.
I carry the cuneiforms with it, so they are all gapping as well. Okay? And then I like to do an inferior glide. So I'm going to draw my hands towards my belly. Okay? And take up all the movement there. And then I'm going to pronate that navicula.
Okay.
And now we've stacked movement in 3 dimensions. And now all I need to do is just focus on the rotation. And it feels like it pronates so freely now. Of course, the joint is tractioned. So I'll just do, you know, about 10 of those.
Okay.
Give it back to you. Okay. I mean, how simple is that?
Yeah, that's pretty cool.
That everts 25 degrees now. And I can overpressure it into eversion.
Okay.
Okay?
Mm-hmm.
Let's have you walk and see if you still have the pinching.
Okay. Yeah, no, I don't.
It does not pinch anymore.
Mm-mm.
Wonderful.
Yeah.
There is one more maneuver that I like to do.
Okay.
Go ahead and line your back again. And on some clients, they tell me it doesn't feel right, and I'm like, gee, I did all this stuff and, you know, restored these micromotions, yada yada yada. But they just don't feel right, and it's a real subtle movement. But I'm going to stabilize the calcaneus here, and I'm going to try and shear through the malleolus and under the malleolus. I'm trying to test that medial glide, primarily medial glide of the talus. It's a real
okay.
subtle. Do you feel that?
Yep.
Okay. And what I find is that when they give me that kind of feedback and I test that motion, it's absent.
Okay.
Okay. So I'm going to test that I'm stabilizing medial calcaneus. I'm going to come on fibula and right below it. And guess who doesn't have the movement?
Yeah.
It's immediately obvious to me that it's like pushing on a brick wall.
Okay.
This one is like pushing on a shock absorber. You know, there's that little tiny bit of play, and you can load it and you can spring it. Mm-hmm. Not this guy.
Okay.
So I'm going to go ahead and treat it, and so I'm just gonna scoop the calcaneus downward,
Okay.
and then I'm going to push left to right, capturing malleolus and just beneath it. This is calcaneus right here. There's a tiny little bit of talus there that I might be able to touch, but everybody's anatomy is a little different, so who knows. So all I'm going to do is glide that talus medially, okay? And I'm not constraining any other aspect of the foot or ankle, and that's my treatment philosophy. Some other people would like lock up everything and just jiggle that, just the talus at, you know, whatever it articulates with several structures. So,
yeah.
But they would lock up movement everywhere except one plane perhaps.
Okay.
I don't do that. I like to leave it all open because I feel like all the other bones participate in this. It's not like only the talus shifted laterally. That doesn't make any sense.
Right.
I don't think that's the way. I don't think that's the way anatomy works. So I keep everything else open, and I am actually able to shear that puppy over to the right or glide it to the right. And there may be a little rotation. I should think there would be a little bit of transverse rotation, you know, and maybe a little bit of side bending, tilt, whatever you want to call it. But the most my greatest effort is in a glide.
Medial.
Okay, and so that moved easily, and I'm going to stabilize one more time, and I'm going to test it. And do you feel that now loads? Now I can take up a little bit of micro movement, and now I can oscillate that. So let's have you walk on that and just give us some feedback.
Okay.
And of course this also greatly enhances proprioception and interoception.
Yeah, feels good.
Feels good. What does that mean?
It just doesn't pinch, and I feel a little more like stable.
You feel a little more stable and no pinching. I'll take it.
Yep.
Okay. Curious, do you feel any different in your low back, SI, hip?
No.
No, you don't. Okay. Alrighty. Well, you know, of course, that has primarily an S1, S2 innervation. Maybe a little L5. Who knows? And of course, so does the posterior pelvis, right?
Right.
Posterior hip has kind of a similar neural pathway. They even use stimulators on the lateral calf, lower leg, for people with bladder dysfunction, because there's a little bit of S2 feeding into the S3 and S4 prudental and such.
Yeah, they'll do the tibial nerve, right?
Yeah, yeah. So who knows these connections? I mean, you know, restoring stability there, this might enhance proximal stability.
Okay.
So anyway, I'm going to look more now at the pelvic structure, but I'll stop filming because I just wanted to capture
Thank you.
the ankle there. Thanks.